All right, so as Walter said, I'm going to be talking a little bit about how we use health equity data in our decision making. So, all of this other stuff that we've talked about already has been really helpful for our OHT in understanding that while we perform relatively well, as an average when it comes to things like cancer screening and other indicators, we also have like very high inequality between our most socioeconomically vulnerable and privileged neighborhoods within our OHT. So there's lots of work to do to close those gaps. So we have the privilege in Ottawa of being co-located with the Ottawa Neighborhood Study and a few other resources which provide very rich local place-based data. So the Ottawa Neighborhood Study works collaboratively with a number of local organizations and community members themselves to draw neighborhood boundaries that are reflective of real communities and allow for rich like statistical analysis still. So they maintain large enough sizes that we can actually work with that data and avoid too much small cell size issues. They also work with the Ontario Community Health Profiles Partnerships, OCHPP, and so we can get some data from them at that same geography. And at the city level, we can also get some data from like Ottawa Public Health, police, and a number of other organizations at this same geographic level. We also have another resource, the Neighborhood Equity Index, although this is outside of the Ottawa Neighborhood Study System. So I'm going to leave it for now, but they are also a very interesting resource if you're interested in looking into them. So some of the benefits of ourselves and a bunch of our partners being on the same place-based system is that we can jointly understand our community's unique, our city's unique communities and their needs, use the same simple language in our collaborative planning. When I say Sandy Hill, everybody at the table knows where I'm talking about. Um, and we can really drill down into talking about what the needs are there and which communities we're talking about. If I say ADA 56092, whatever it is, that's a lot harder for people to come together around, rally around, and understand. And this also allows us to integrate lots of data, health outcome data, system usage data, population health, and social determinants of health, all from a number of sources when we're using the same system. So we have StatsCan data, data from Inspire through OCHPP, HSPN data, and we're working right now with our hospital partner, TOH, and the other hospitals in our area so that we can have a data pipeline to get hospital level data from all of those hospitals at this same geographic level as well. So that's gonna, yeah, we're very excited about that moving forward. So this is just a little example. We know from looking at our community that standard geographies like aggregate dissemination areas or FSAs, which are, for the Postal Service, these don't necessarily reflect um, real communities and often actually hide equity and health disparities. So on the left here, we have an ADA, and when we look at a bunch of health indicators and marginalization and equity indicators for this ADA, it comes out as pretty average across the board. When we look though and break it down into real neighborhoods, we can see that on the left in Billings Bridge, we actually have one of our most socioeconomically vulnerable neighborhoods. And on the right, Alta Vista, one of our most socioeconomically privileged neighborhoods. And there's quite a big difference in the population groups. And health system utilization between these two very distinct neighborhoods. So our OHT loves place-based planning, and so in our recent work around interprofessional primary care team expansions, we developed a primary care dashboard for our OHT partners utilizing a lot of place-based data. So we have here our primary care practices and their sizes for our geography of responsibility. And then we have some primary care attachment indicators. We were able to get some age segmented attachment indicators through our partnership with HSPN for these neighborhoods, which allowed us to see that there was a big difference in attachment rates across age groups by socioeconomic vulnerability. In the neighborhood, we could see that in our most socioeconomically vulnerable neighborhoods, the rate of unattachment for children under 6 was much higher in that age group specifically, with I think our Q5 neighborhoods were like 1 in 3 children under 6 were not attached to primary care on average. So that tells us, we need to be doing some work in these neighborhoods for better attachment for newborns and young children. And then we integrated as well some population health data, focusing on our priority populations, sociodemographic data from the census, and some social determinant of health data as well. And looking at this, I'm going to go back to these two neighborhoods here. So again, Billingsbridge on the left is one of our socioeconomically vulnerable neighborhoods, and Alta Vista on the right, one of the most privileged. So when we look at unattachment for this ADA, we can see it's pretty average, about 16% of the population there is unattached to primary care. But when we break it out, we can see that in Billingsbridge, Heron Gate, it's actually much higher. So about 23% are unattached versus about 14% in Alta Vista. And the age groups there also differ a little bit as well. On the right there, when we look at cancer screening as well, we can see in Billingsbridge, Heron Park, almost half, about 46% of eligible people are not up to date with their breast and cervical cancer screening, where that goes down quite a lot to 32% in our more privileged neighborhood. So, and again, that's a percent of residents not up to date. So the higher the number, the worse it is. And we can see this reflected very clearly across all of our neighborhoods. With our most socioeconomically vulnerable having much worse screening rates. So once we identify those disparities, what are we going to do about it? So we look at our breakdowns of some sociodemographic factors. On the left, we have Heron Park and Billingsbridge are socioeconomically vulnerable. And we can see that the breakdown is very different in the demographics compared to Alta Vista. So the percent living in low income is like 23 versus something like 4% in Alta Vista. Our percent of racialized residents is much higher. It's 38% versus 22%, and specifically a much higher proportion of residents who identify as Black in Heron Park, Billingsbridge compared to in Alta Vista. So there are some considerations there for our planning. If we're looking at doing cervical cancer pop-up clinics, we need to be considering that most people are probably relying on public transit. Do they have limited work hour flexibility? Are there childcare challenges? Do we need to have a childcare friendly space? Are there actual risk disparities between different populations that we need to consider? And what are we going to do about cultural safety and developing close partnerships with organizations who are already working and have trusting relationships with residents here? And then we can also use some social determinant of health data from the Ottawa neighborhood study to see some barriers and enablers. So we can see in Billingsbridge, Heron Park, about 28% of renters are living in subsidized housing. So, are we going to advertise our pop-up clinic at all of these buildings with that housing partner? Are we going to host them in the subsidized housing buildings? Is there a cluster there where we can do a pop-up clinic specifically for that population? Similarly, we can see that quite a high proportion of residents live within a 15-minute walk of the local CHC. So are we going to host our clinic at the CHC and arrange transit options, shuttle buses to subsidized housing buildings that are outside of that radius? What are we going to do to further enable populations there to be able to participate in our initiative? So I get excited about this. This is the stuff that we love to do with this data. And I think, I guess if I had to share a takeaway, something that we find the most valuable is having those small shapes, those neighborhood shapes in Ottawa that we can all get on the same page with. So if you have any opportunities to develop neighborhoods with your partners, doing that in collaboration is so helpful. Um, yeah, I would just say that it's a huge boon to our planning. And if anyone has any questions, please feel free to shout it out or send me an email as well. You can let me know. Thank you.